I'll ask you to click yes if you hear that like really creepy recording in progress voice, okay? So recording in progress. Tonight we are talking about bedwetting. My name, you can see it on my little name thing there. My name is Vanessa Vega. I'm a physiotherapist with a special interest in pelvic health. In this scenario, we're talking about pelvic health for kiddos, right, under the age of 18. So, okay, so I always like to keep an agenda so we understand what's going on tonight, what can you expect from tonight, and to know if you have any questions at all, that's when you can jump in. If you're thinking of a question that's upcoming, you can kind of get an idea of when that is coming up. But essentially tonight's topic is going to go over kind of who am I, what's physiotherapist. We're going to go over some very basics of the urinary tract system, anatomy that's relevant to treatment. And I have to kind of share the education side of things so you have a better understanding of like, why are we talking about these treatment options for kiddos, or why we're even addressing certain things. Okay, that's why we have the basics of urination. We get into bedwetting, and obviously I want you to have some takeaways for what you can start doing right away. Okay, at the end, we're giving some space for questions. I believe we're probably going to take about half an hour of time. I imagine it just depends on how fast or slowly I speak. And obviously, if anybody has any questions that come up. Okay, I think there's the ability to like raise your hand in the side. If you wanted to use that feature, I think there's like a little click and I should be able to see it on my end, whether you have any questions. Okay. If you put anything in the chat box, I can also see that. So by all means, if you don't feel like raising your hand or interrupting, just type it in there. I will review it as they come. All right. So who am I? So a little bit about who am I, because obviously this tends to be a little bit more of a sensitive topic when we talk about pelvic health, and especially when we're talking about it in kids. So I do want to share who I am and why I'm speaking about this. Specifically on a personal level, I am a mom of 4 kids. The oldest is about to turn 7. The youngest are 2-year-old twins. So being able to see them through their development, seeing them go through potty training, all those sorts of things, I have that understanding and perspective as a mother. On the professional side of things, I am a registered physiotherapist, have been one for about a decade, and have been working in some aspect of pelvic health for about the same amount of time. It's been an interest of mine for a very long time. I'm very passionate about it. I have been working with a lot of prenatal postpartum clients for many, many years, and I've chosen to move towards the kids simply because I saw a lot of adults struggling with things that probably developed in childhood and things that could be caught at an earlier stage. The other thing that I find is very interesting is when we learn about kids, we understand that as moms, we're starting to get a little more comfortable with the fact that we talk about jumping on trampolines and people have a bit of a giggle over how people pee their pants or have any type of leaking when they join CrossFit or jump on a trampoline. And when it comes to kids, we have a little bit of the psychological impact of dealing with any type of urinary incontinence, fecal incontinence. The fact that they can't really communicate as well as we can as adults, I felt really driven to help this population simply because of that. And the things that we want to catch when they're still really young, so we can prevent certain things happening as they grow older. So yes, the psychological impact can cause stress, it can cause frustration, feelings of failure in these types of kids. And I want to make sure that they get the best chance at not feeling those things in their life. And also thinking about these kids that end up having issues, and children can grow up in having to have UTIs, sensations of urgency, that need to go to the bathroom all the time, urinary retention, constipation, painful bowel movements, painful bladder syndrome. So things that we can really catch when they're kids, and simple things that we can catch when they're kids, right? Before they even really start diving into in all the fun things that come with life. Okay. Specifically when the topic tonight is on bedwetting, and the reason why this came up as the first topic that I'm doing as a webinar for our kiddo population is just because of the fact that there are quite a number of children who deal with this. And most of the time, I feel like parents don't really talk about it to each other. They don't really have an idea of what to do with these kids. It's just that unspeakable, we have no idea. So we just kind of leave it. And I feel like it is something that we can address quite easily. And again, understanding that kids who deal with bedwetting again, have poor self-esteem, the frustration, the anger, the ability to not participate in certain things like their peers can. And that really affects their development. So that's why I wanted to touch on that in this particular instance when dealing with pelvic health in this population. Okay. So first, the reason why I have just this image about what we kind of look like from the side, right? So if I turn myself to the side, cut myself in half, this is what I look like, where you could see this would be your stomach side, and this would be your back side, okay? The leg is kind of coming down here. I wanted to give you a little bit of a glimpse as to what this looks like, because when we're dealing with incontinence, we're talking about like the bladder and the urethra, right? So this front organ here. But they're so closely tied to all the organs that are right at that pelvic outlet, okay? So obviously this is a female anatomy, and we can see how close it is to the uterus and the vagina, as well as looking towards the rectum. And I wanted to show you, I mean, this is a nice depiction, but how closely things are tied together and why we kind of address a bunch of things from the pelvic health physiotherapy side of things, because they're so interrelated. And our research is just showing how much stuff from the rectum, so things like constipation, can really impact what's going on the bladder side, because you can kind of see if this tube is filled with a lot of poop, it can put a lot of pressure on our bladder and our urethra. And it does have an impact in terms of how kiddos can go to the bathroom, or if they're having that sensation of having to go to the bathroom or not. Okay. On top of that, as a pelvic floor physio, one of the things that I tell a lot of people, my adult population, my kids, is that we're looking at, everyone always thinks that we're just looking at this little area in isolation, and we're not. We're looking at sort of how your posture is, what's going on back here, how is your tummy muscles. We're looking at you on the bigger picture, because all those things play into how everything sits in your pelvis. Okay. So this is a very quick, little brief an idea of what's going on. What I want you to take away from this is just understanding how closely things are related to each other. When you're looking at anatomy, yes, your bladder sits to the front and your rectum is behind that. Okay, closely related there. I do have notes to the side because I do have to make sure that I stay on track. So if you see me looking over here, it's just because I'm making sure that I'm addressing everything. So urinary system, this is what we're talking about specifically, because this is when we're dealing with incontinence or leaking. We're obviously talking about the urinary system. So I wanted to highlight specifically the bladder. And the reason why I share this is very simply, like I'm teaching you right now, this is what I teach my adult population, what I teach kids on their own level of understanding, right? Depending if they're 5 or if they're 15, we have a discussion about what the urinary system is, because the more they understand that, the more they understand what they have a control of, or maybe what they don't necessarily have control of, well, what they can feel a little bit more empowered by. So here's the basics of the bladder. It isn't just a storage unit. It does act as a sensory system, and it has a big muscle that wraps around it. And this whole thing works as understanding that when it fills, it has a sensation of fullness, and that muscle helps us to empty out the bladder, right? Because it squeezes the balloon empty, so we can actually release everything that's in the bladder. On top of that, there are 2 sphincters. Now I tried to find the best image to show 2, but it doesn't. But there is an involuntary one near the bottom, near the base of the bladder. It's an involuntary one in the sense that it's just an automatic response. Just like our nervous system controls our heart rate, I can't say heart rate beat at a certain level. My body does that on its own. The same thing happens with the sphincter here. It's something that we can't control. It's an automatic response, i.e. our bladder fills up to a certain level, and now our bladder knows that this muscle can relax and this muscle can squeeze so that we actually go pee. So again, this is something we can't control, right? When our muscle, this bladder muscle squeezes, we don't have control over that squeezing. That's just an automatic response. What we do have control over is more of the pelvic floor muscles here that act as that second sphincter to that outlet of the bladder. So I teach kids, just like I teach my adults, about why this makes sense. Why are we looking at certain muscles? Why do we talk about the pelvic floor? Because it's what closes that tube. If nothing's closing that tube, then we get leakage when we don't want it to happen, because everything else keeps running. Okay. So how the urinary system works. Like I kind of mentioned, this bladder fills. It reaches a certain point where we start to sense fullness, and it starts to tell us we got to go. but we don't go automatically when we have to go, right? We have to wait, sense that it's full, and actually get to a bathroom to release everything. So we have that ability to kind of shut everything off, right, at that outlet until we get to the bathroom. Once we get to the bathroom, this kind of reflex is that we release these muscles, we relax, and that tells these other automatic muscles, automatic responses to just go. Okay. That's what I wanted you to understand, because this is what you're going to help teach your kiddos if this is what you need to work through. Okay. We can review that as well. So to keep going on the role of bladder and fluids, I feel like we talk about this in every single population, but how important it is to make sure that you're having enough water. And the same thing goes for our kids. When that bladder is filling, understand that it's sensing fullness, that bladder, but it also gets irritated by certain things, because that muscle can become twitchy if certain things irritated in the bladder. So in this case, what I always think about is what makes that muscle twitchy is if that urine is overly concentrated. Think about it being like really acidic. The bladder doesn't like that, and it tends to become a little bit more twitchy, which means that we sense like we have to go pee more often, or it becomes difficult to stop the flow because that muscle just keeps squeezing. Okay. So I like this just because you have a little bit of a guideline as to what kids should be drinking, or at least a range of what their water intake should look like, as well as understanding sort of what you're looking for when they go pee, right? And I usually feel like, if anything, I know it's really hard to calculate how much water intake kids are having, but at least having an understanding of what their urine looks like will help you have an understanding of if they're drinking enough or not enough. And being able to empower the older kids who are able to look at their own pee and have an understanding and being able to modify themselves is a great tool to have. What I've just added as well here is just that normal voiding. So how often you go to the bathroom is about 4 to 7 times a day. Okay, and that's a nice number to have, because we are going to talk about that number a little bit later on and how you can use that in helping with bedwetting. Okay. So then we talked about how close the bladder is to the rectum. We cannot ever talk about incontinence or any bladder issues without also looking at what's happening on the bowel movement side. So in my practice, we have a lot of discussions, both pee and poop, and we get comfortable talking about it. So as I already mentioned with that bladder picture, you can understand how if something is really concentrated in that rectum, and that rectum has a lot of give, right? If someone's constantly constipated and there's a lot of pressure in that rectum, that pressure can push on the bladder. And that still causes that pressure on the bladder that then maybe makes it go twitch a little bit more frequently, like, right, give you the sensation that you have to go more frequently, which also makes it harder to stop the flow of urine. Because if we think about the fact that anything that's in the rectum could be pushing on the bladder, and now it's doing this all day long, and we still have to be able to squeeze that urethra, that tube closed all day long, eventually it gets tired, and that can lead to incontinence as well. This is just a Bristol stool chart. You can quite literally Google this and print it out if you'd like it. Again, it's a nice tool to use for kids and parents alike to have an understanding of if they are constipated or if they're doing well. And one of the, I think, shocking statistics that I heard in kids particularly is that even if kids have daily bowel movements, and that's the thing they were thinking, right? My kid goes every single day, they must be okay. Even with daily bowel movements, 50% of kiddos are still considered constipated. You would know that because you would see these firmer stools. And what we're hoping for is more somewhere along this type 4. That's what we're aiming for at all times, right? Because type 4, type 5 might be a little bit, it's like type 4, type 5 that we're aiming for. Then we're thinking like type 3 to 1 is much more constipated, and type 6, 7, obviously we're on the loose end. We could get into a lot more details in terms of constipation, because everyone thinks that constipation means like you never go. There are kids who deal with fecal incontinence because there's just so much in there. Like it's a big plug that the looser stuff starts to move around it. Okay, so there is such an example where you can be constipated and deal with this type of stool. Okay, so what we're aiming for is this type 4 to 5 and knowing that we have to address things if you're kind of more in that top range or bottom range. So I just see something's popped up in the chat, and I'm going to read it out loud. So if a child has a fuller rectum, not pooping enough or regularly, it can make them have to pee more. Correct. Yes. In some instances, yes, some kids may have to pee more because they're experiencing pressure from their rectum, and that's causing them to pee more frequently. Okay. Or deal with incontinence. Okay. So that's my little spiel on the poop side of things and why we actually look at what's happening when kids go to the bathroom on the bowel movement side. Okay, so now we're talking about sort of what does development look like as kids get older, the potty training phase, et cetera, and why are there certain ages? So understanding that we have to think about our bladder system, and being able to use the bathroom involves more than just, I think they're ready or they're showing signs, right? Because we do have to have a really good neurological system, right? So that nervous system has to be good and intact for all these things to obviously make sense. And knowing that if our nervous system or our muscular system is not intact or mature, that these dates will change or these ages will change. Okay, so we're thinking in a normally developing child with an intact nervous system, intact musculoskeletal system, okay, or the muscles. So thinking that awareness of what's my bladder doing is sometime around the ages of one or two, because you have to have that awareness to know, okay, I'm pretty sure I'm feeling my bladder is full and now I need to go to the bathroom, right? That's very key to understanding that you're not going to overfill your bladder or underfill your bladder and constantly go to the bathroom. That sphincter, that one that I talked about, that's the one that's voluntary that you can control, is somewhere around age 3, right? So they have that ability to go, I'm full and I got to close things off to get to the bathroom, right? And then there's the other pieces that come into understanding when someone's ready to go to the bathroom, is being able to cognitively know. So are they able to think about the fact they need to void, right? They need to go to the bathroom. They need to go in an appropriate place. They need to find a potty, get to the toilet, close the door, undress themselves, dress themselves, and flush. Right? It's a step-by-step process. So that is really what we consider when we think about typical bladder control and being able to go to the bathroom. I also added this information in terms of daytime dryness, because kids can get potty training quite quickly, but it's the nighttime stuff that lags, and that's normal. And we're looking at about 10 months. So once they're dry consistently during the day, by 10 months after that, they should more or less have that nighttime control. Okay, and then again, this is another statistics understanding. Sometime around preteen, they're voiding about 4 to 6 times a day. Okay, so going to the bathroom too much, going to the bathroom too little is something that we want to address, right? Because if they're going too little, then there's a fluid intake issue. That bladder may be getting too full, right? And we don't want that also to stretch out. If they're going really, really frequently, then their bladder isn't getting that sensation of fullness. Do they have an ability to hold it? There's all those sorts of questions that kind of come up when we see that kids are going too frequently or not enough. Okay. I'm done that page. All right, so now we're actually moving into the actual bedwetting discussion. The scientific term that we use is enuresis. It's this nice little pretty name. So this has to go into a lot of details in terms of the fact that we define bedwetting differently. And the reason why I'm sharing this is just because we address each individual kid differently. Okay, so I'm going to go through these terms and I'm going to try to go through them slowly so you understand why I'm breaking this down and why, as a physio, I would deal with them differently, and there'd be kind of different discussions. At the end of this, we're still going to kind of go over what can you do right now, okay? So the first terms are monosymptomatic versus non-monosymptomatic. This basically means either your child only has bedwetting issues and nothing else when it comes to the pelvic health area, or they have one of the following things. So things like that overactive bladder is that twitchy bladder. Okay, so that bladder that constantly feels like it has to go, they're going quite frequently. That's an overactive bladder. Urge incontinence, similar with the adult population. So that's that feeling like when I got to go to the bathroom and I'm running to get there, that's when I still get some leaking. Stress incontinence is leaking when you're doing something active. For kids, most of the time this shows up in a sporting thing, playing on the playground. That's when they leak. And I'm cut off here, but it's voiding postponement. Voiding postponement is kids who do different things, so they either do like that potty wiggle, that dance, they may put their hand around their genitals to close things off. They'll do this funny maneuver where they look like they're squatting and kind of putting their foot along their bottom, like they're trying to hold things in. So they're doing a lot of things to stop themselves from going, but they still get some incontinence or leaking. Underactive bladder. I like to think about this as like a lazy bladder muscle. They don't go very frequently. They're needing to push to go pee. Like it's like that bladder doesn't want to squeeze everything out, and they're just feeling like they need to push a lot or nothing ever fully empties. In our younger kids, they won't necessarily recognize that they still feel like there's more urine left. The older kids will kind of have that sensation and can communicate the sensation that they don't feel like they fully empty. That's underactive bladder. A staccato flow. So that sounds like if your kid's going to the bathroom, it sounds like it's like on, off, on, off, on, off. Like it's just not a smooth flow, because a normal urinary flow kind of sounds like it's like a bell curve. So you could kind of think of like it's a slow flow, it gets faster, it gets at its peak, and then it slows down. So if you have a kid who goes to the bathroom and it seems like it's very sporadic or there's spraying, it's very like an odd flow, then we kind of consider that as a non-monosymptomatic. It's not just a bedwetting issue. And the final thing is giggle incontinence. Essentially, they leak whenever they're laughing. Okay, so in this case, our statistics show that less than half the kids who are dealing with bedwetting are just dealing with bedwetting. So that means the majority of them are dealing with other things during the daytime or other symptoms that also has to do with the bedwetting. Okay, our next term, we're talking about primary or secondary, and that essentially means primary bedwetting or primary enuresis means that they've never really had dry nights for 6 months. Versus secondary is like they were dry for 6 months overnight and now they've developed bedwetting. Okay. I wanted to break down. So some causes of primary enuresis could be genetic. So there are some cases where a parent has had bedwetting issues or incontinence issues for their life. And that actually passed on to the kids. And what's great is we have data on this, that if with one parent with bedwetting, chances are there's a 40% chance that their child will also experience the same. With two parents, it's a 77% chance. In this case, there's a big link between a hormone that decreases our kidney function, and our kidneys have to do with getting all the fluid out of our body that goes into our bladder that we then are able to pee out. So genetically, they're seeing that these people lack that hormone, which doesn't allow that kidney to turn off at nighttime. So you're still doing the same thing, right? Because it should, when you're sleeping, that means your body knows, kidney, slow down. You don't need to process all that fluid so that you can sleep for the whole night, and then you can wake up in the morning and have to go pee, right? Because it's not like during the day where you can go to the bathroom every 2 to 3 hours. Okay? This is relevant to when we talk about treatment as well. Sleep disorders. So kiddos who snore, kiddos who are a bit more of mouth breathers, what the research is showing is that it's interrupting their sleep. So that is also not telling that hormone to be released so that the kidney shuts off. So oftentimes with these kind of kiddos who are dealing with snoring, if we treat the snoring, if they're no longer snoring, they'll have better sleep or that deeper sleep so that the kidney shuts off, and now they're not dealing with any bedwetting. Okay. And there's also a link with ADHD when it comes to that never had a dry nighttime. Secondary, I like to highlight this is just to know that if you've had a kid who's been dry for 6 months overnight, that there's some things that you need to look at, whether they're having chronic UTI, they have diabetes, there's some psychological factors like a new baby, negative attention, just other things to address when it's been 6 months of consistent dry nights, right? Like no issues. Okay. I'm sharing the data here because, again, I want to highlight the fact that it's not just the one-off kid, right? 15% of girls will deal with bedwetting, 22% of boys. 10% of 6-year-olds still continue to wet at nighttime, and there's a 15% spontaneous cure rate per year. And what I like to highlight with that, because a lot of times people will just go, wait it out, when you can start to address things at 6 years old, right? Because 15% is still a small portion of those 10% who are recovering, right? So there are things that you can start to address. And by 18, there's still 1 to 3%, right? And we don't really want them to get to that age because then it's a long, many, many years of the same habitual practices. So also noting again, 10 to 25% of those who wet the bed at nighttime are also wet during the day. And also 10 to 25% have problems controlling their bowels. So that's why we're looking at a lot of things when it comes to bedwetting, because it's not always just bedwetting that's going on. Okay. Let me flip my little page. Okay. So what you can do right now. So this is one that if you are a fan of taking pictures, by all means, take a picture with your phone so you can look at sort of the bladder irritants, because we are going to talk about that. So simple things that you can do right now are behavior modifications. My first note there is starting a bladder diary. A bladder diary, what it looks like is essentially tracking fluid intake. What kind of fluid, right? Because it could be water, it could be carbonated beverages, it could be juices. When are they going to the bathroom? And for some kids, I'll mark like, are they leaking? Or do they feel like they have to go to the bathroom and then they pee very little? It's tracking what's going on with their fluid intake and what's going on with their output, or what are they peeing out, and documenting across a day, right? So it could be like 6 a.m. Are they waking? Are they going to the bathroom? 9 a.m. All those sorts of things. It gives you a better picture of what's going on. Look for bladder irritants. So I have that list there. These are things that we know are bladder irritants. And we talked about this at the beginning, where that detrusor muscle, that muscle that surrounds the bladder, can become, I always talk about it as like twitchy. So it starts to squeeze that bladder. And these are the types of things that can irritate it. Okay. So even in adults, really, when people are having lots of orange juices, acidic foods, caffeine, that's a big one for a lot of adults, because everyone has their morning coffee, and that can be very irritating to the bladder. Carbonated beverages, milks. So think about like when you put your kid to bed at night, and everyone thinks about that old saying about like giving somebody warm milk for them to go to bed. Probably not a good idea if you're dealing with a kid who's wetting the bed, because milk is, again, a bladder irritant, and that could cause that bladder muscle to get a little twitchy at nighttime. Okay. Artificial sweeteners, chocolate, food with red or blue dye. So this is just something to keep in mind. If you're dealing with a kid who's dealing with incontinence or bedwetting day or night, these are smart things to just keep in like a little post-it note or something wherever you go, so you have an understanding that these are the types of things that you'd want to limit in their diet, so they're not dealing with it's a disadvantage, right? If you're already dealing with incontinence and now you're having orange juices and spicy foods, then you know that you're going to have to deal with it even more, particularly that day. Okay. Water intake, right? Making sure that they're having enough water, because the more concentrated the urine is, again, that becomes a bladder irritant. And then that becomes, again, that twitchy muscle that's going to make you have to go more often. I also have a note, if you jump to the last line, decreasing fluid intake only before bed. And it's only before bed, because we obviously want them to have enough fluid during the day, right? To keep themselves hydrated, so we have that nice urine color. But before bed is where we want to kind of peter it off, because we want to make sure that we're trying to give them the best chance at being dry through the night. So after that water intake, I have interoception practice. Interoception is that inner knowing or inner feeling of your body, which is actually a learned thing. Interoception is that feeling of like, you know how you can feel your heart racing, or when the heart feels like it calms down. Interoception is that feeling of my rectum is full, or my bladder is full, or my bladder feels empty. Interoception practice can be something as simple as going, if your kid is kind of dancing around, you go like, do you feel like your bladder is full, or what makes you feel like you have to go to the bathroom? Right? It's just verbally having these conversations about what makes you feel like you have to go pee, or what makes you feel like you have to go poop. And the more they start to think about what are they actually feeling, the better that they get at feeling those things. And being able to sense that bladder fullness, that rectal fullness, will get them better at understanding when they have to go to the bathroom. Okay, so having those conversations more frequently throughout the day. As I mentioned, constipation, it's a big one. We want to make sure that if someone is constipated, that we're treating that, because no matter what we do for the bladder, how good we get at strengthening that pelvic floor muscles, removing bladder irritants. If a kiddo is constantly constipated, they're again at a disadvantage and they won't see as positive results as if we treated the constipation. Okay. I have a list there again of constipating foods. These are pretty common in, I would say, most kids' diets. So again, being aware of the fact that if they're dealing with a lot of constipation, these are the types of things that you may want to start to remove so that they're not dealing with it as much. All right. Oh, the one thing I didn't add in here was behavior modification would also include if kiddos, if they're snoring, right? Because if you fix the snoring, then they're going to have that better sleep quality, which will put them into that state to turn off the kidney so that their bladder isn't constantly filling overnight. Okay. So things you can really start to tackle right now. So now we go into the what else. And I personally have, from my personal story, ever since I shared that we'll be talking about bedwetting, I'm getting nonstop ads on my Instagram and Facebook for all sorts of bedwetting tools. There are lots of tools out there. A lot of them are called different types of alarm systems. So these are usually something that you can put into the bed. It senses when there's some wetness going on. So what this alarm system does is essentially the kid goes to bed like they do any other time. When that alarm goes off, the basic concept is that they learn to wake up and go to the bathroom and come back. What we're seeing in terms of the research side of things is alarm systems work great for a good portion of the population if they're consistently followed, but there's also a lot of relapses. And what we're showing, or what the research is showing, is that there's improved results from using alarm systems if they're also practicing squeezing their pelvic floor. So for example, and this would be like the alarm goes off, the kid actually is cued to squeeze your muscles, right? Don't let yourself pee anymore. Then they are able to get up and go to the bathroom, right? So the more that we actually train them to use the muscles instead of just respond to go to the bathroom, the better chances we have. This does require equipment, right? It does require equipment, technology, whatever it is. And there's lots of equipment out there that can be either pricey or not. There are some relapses. And sometimes what ends up happening is kids can learn how to not wet the bed, but it turns into what we call nocturia, which is essentially just getting up to go to the bathroom at nighttime. So instead of wetting the bed, they get up every morning at 1 a.m. to go to the bathroom and go to bed. Okay, so these are just like side notes of what's going to happen. So we usually jump to behavior modification and other things that we'll talk about after, and alarm systems. And one of the medical managements is this drug that's called desmopressin. So this is really good for those kids who have a genetic link, right? Because it actually deals with that hormone that decreases that kidney function. And the concept there is if you've tried other things and nothing seems to be working, right? You've addressed constipation, you're doing alarm systems or this other system that I'm going to teach you, and nothing really stops the bedwetting entirely. Then there's the option to go for the medication that's either temporary or for longevity, right? Because if there's a genetic link, chances are it doesn't just go away. Okay, so there is medication that is sometimes offered. It's not the first thing that's offered because there is other things you have to go through, but there is this. All right. Oh, and understanding too with alarm systems that if you have a change in routine, if there's a change in fluid intake and change in their diet, that sometimes they will relapse, right? Because now their bed routine is essentially different and they're going to bed with different amount in their bladder. Okay. So I wanted to teach you this other dry morning program. Okay. You can't really Google this to find it, but I have laid it out pretty clearly in this slide. So again, take a picture if you want to, so you have an idea of what to do for this. It's taking the concept of the alarm and it's taking it a step further, and kids are showing pretty good response to this type of program. So the concept is we can only use this in kids if they're able to squeeze their pelvic floor muscles in sitting position. Okay, because we are relying on them to be able to use those muscles to stop themselves from going pee. So what you end up doing is you spend 1 week documenting when at nighttime they're going. So this is a little bit of a sleepless week for caregivers, because what ends up happening is so kids tend to wet the bed either in the first 4 hours if they go to bed or 1 to 2 hours before wake up. So the idea is the first week, let's say it's a Monday, they go to bed at 7 o'clock. You go into the room at 8 and check to see if they're wet, right? Go into the room at 9, check to see if they're wet. Go into the room at 10, check to see if it's wet. Go to the room at 11 p.m., check to see if they're wet, right? So this might be for kids who are in pull-ups, right? You'd have to actually check to see if they're wet. The idea is that you're not really waking them up during this time. Then if they usually wake up at 7 in the morning, you're checking at 5 a.m. and 6 a.m. to sort of get an idea of when are they actually wetting the bed. And kids tend to be pretty consistent as to when that is. So the idea is you kind of like document, you get data. So now let's say the same kiddo that goes to bed at 7 p.m. always wets the bed sometime around 10 p.m. So now you spend the next week, you're going to get them up before they wet the bed, right? So they tend to go around 10 p.m. We're going to get them up sometime around 9:30. You wake them up. We work on that skill. Do you feel like your bladder is full? You get them up, go to the bathroom, they go pee, they go back to bed. You say, good job, back to bed. And then they stay in bed for the rest of the night. You do that every single day for a week, right? And as soon as you have 7 days of dry mornings, then you change that time by 15 to 30 minutes. Okay, so now if we're talking about that, they go pee sometime in the first 4 hours of sleep, and we talked about that 9 p.m. kid, then we would wake them up at, 10 p.m. kid. So we work them up at 9:30. Now we're going to wake them up at 9 p.m. Then you wake them up at 8:30 p.m. And now it's too close to their bedtime, so that then you start to work on like 8:15 p.m. And we don't go any closer than 1 hour from after they go to bed or 1 hour before they wake up. Okay. So it's a training program, and it does take some time and effort from parent and child, but this is kind of that weaning. So they're not just responding to an alarm, right? Because an alarm just becomes a cue, like alarm, go pee, alarm, go pee. But it doesn't necessarily teach them how to control that bladder or change that endurance of their bladder. This program helps them a little bit more with regards to having that interoception, that sense of what's going on in their body, and being able to progressively increase the length of time that they're sleeping. All right. What else can you do? So obviously I'm going to say pelvic floor physical therapy, right? Because we address all these types of things. We look at what's going on with their lifestyle. We talk about modifications that can happen in the home. We talk about posture. We talk about the muscle strength of the core and pelvic floor, because we know how important that pelvic floor is and being those sphincters for both bowel and bladder. We know that muscle needs to be used in kids. We know that they need to be able to squeeze it, and we know they need to let it go. Okay, so that's our big role, is actually teaching them. Guidance and accountability for recovery, right? We modify, we tweak, we understand how to change things for kids' lives so that they can continue to live the life that they want to do while we're still working on recovery, right? I put off that we're hands off as much as possible, right? In terms of like, people mostly think of pelvic floor physical therapy when they talk about postpartum women. In kids, it's quite different, right? We have a lot of parent involvement. There's a lot of time spent educating kids, and there is some time spent on looking at their pelvic floor or teaching them how to squeeze certain muscles, right? Much more hands off. Other things, there's a lot of evidence to show that even just what we call urotherapy, or educating kids on what their bladder is, what their bowel is, how all those things work together, has a lot of good positive results in kids, right? Just having an understanding of what's going on with their body can really help them take control over a lot of things. Okay, that's part of what we do as pelvic floor physical therapy. That's part of the reason why I gave you a lot of information at the beginning with regards to bladder, bowel, how those all work, because you can explain that to a 5-year-old, you can explain it to a 10-year-old for understanding and getting an idea of what their understanding is of their own body, because their own understanding will help them recover even better and faster. Books. There's a lot of books out there. There's a lot of very positive things, and we want to come at this from the angle of it's not your fault, right? Because a lot of kiddos can wet the bed or have D-time incontinence, and it feels very shameful or frustrating. So these books are kind of helpful in demystifying the fact that like it's their fault. They get frustrated, like those types of things. There's a lot of kids, there's a lot of books for different ages that are appropriate for them, so you can actually have a read through. And some of them even give you even more tools as the parent, right? Particularly like you can go to the potty and bedwetting. I can't read the whole thing. That one is a really good book as well. Okay. So there's lots of things that you can do on your own as well. And these are accessible by like Amazon, right? You can just buy them and have a read through them. Okay. So to end off, how do you find me? I'm at Oscar's Place. I have the number right there. You can give a call. You can see the lovely ladies at the front desk and have a conversation with them. My email address is there as well. I'm always happy to have a conversation of if you don't know if I can help, right? Because I understand that for our own health as a parent, we kind of have an idea of where we can navigate that. But for our kids, we just don't always have an understanding of who can be most helpful in what scenario. And honestly, in some cases with some kids, there are other avenues that I need you to take before you see me, right? So it just depends on your kiddo's case. Always happy to have a conversation with regards to what's going on with your specific kid and see how I can help. Okay. So I leave this as my last slide because I'm opening this up for any questions that anybody might have. Again, if you really are more comfortable popping in the chat, type away. And if you'd rather just unmute yourself and ask a question, by all means, go ahead. Okay. I'm just gonna open up the chat so I can see it. You're welcome, Karen. Anybody else? I know, I feel like sometimes there's a lot of information that it's like, what kind of questions do you have? Cool. Okay. Always here if anybody has a question. How common is nearly 6-year-old not ever being able to have dry nights? So it's a tough, so if we go back to like the information about, here we go. So 10%, right? And that's not broken down in terms of like what are the primary versus secondary, but assuming that there's no other issues that really happen, we're going to assume most of these are primary. They've never had a dry night. So you're looking at 10% of 6-year-olds, right? So in a class of 100, there's 10 of them. In a class of 10, there's one kid who's never had a dry night, right? It depends on the fullness of the pull-up that they're wearing. Like, is it always full? Is it a little bit? Do we know when they're waking up? Do they have that sensation? And also asking the question of, are they having any other issues, right? Are they able to are they able to squeeze to stop the toots from coming out, right? Because those are lots of the things that I ask to have an understanding if these kiddos can actually use those muscles, okay? Potty trained during day for a few years, some accidents still could be ADHD. It could be, right? If so, in this case, if you have someone with ADHD, those things play a fun, complex side of things, right? I would really say that obviously in my case, I would want to see what your 6-year-old is capable of doing, right? And you said some accidents still for. So it's hard to say, she might be a little bit slower to get those sides of things. And again, we know ADHD, those are linked to more of where's my stats here? Yeah, primary. And that's once ADHD is linked to those kids who don't have dry nights for 6 months, right? They don't start off that way. Okay, so the issue we're running into is my son will wake up in the morning, doesn't even know that he's gone. I will change him in his bed and he still has no idea in the morning. Oh, so you're changing him in the middle of the night and then he wakes up and doesn't recall those types of things? There's some kids who are deep sleepers. Is he in up? I'm assuming he's not in a pull-up. He's just like obviously in bed. I don't know if you want to unmute Michaela to answer my questions or, oh, there you go. Yeah.
He hasn't been in a pull-up in probably a year.
Okay.
And he just now, probably within the last, he had accidents off and on at the beginning, but it seems now, since he's back in daycare and he's busier during the day, that he will he'll come into our room. I will take him back to his room. I will undress him, redress him, change his bed. He'll wake up in the morning. He'll be like, "Mommy, why do I have different pajamas on?" And I'm like, "Because you had an accident." And he will get so upset. He's like, "I didn't, Mommy, I didn't." And it's like, but you did. So I don't know if it's just he's sleeping so deeply that he's not that's kind of where I'm at. I don't even know what to do because he doesn't even realize that he's doing it.
Yeah. So, and he's 4. So he's a little bit on the younger age group for incontinence at nighttime. So I wouldn't be overly concerned because then we're talking about when we talk about bladder control and all the things that need to be in place. So it's Is he just turning 4? Because so he just turned 4 because it sounds like he isn't in school yet, right? He's at daycare.
He's a January baby, so he'll be 5 in January.
Okay. Yeah. So he might still be on the younger side. Like if this is happening every night, or is this more like once a week, once a month?
I'd say maybe 3 times a week.
Okay.
He'll go in spurts where he won't have any accidents for like a week or so. And then it seems that once he has one night, he'll go like 3 or 4 nights having an accident, and then it'll stop. Like there seems to be kind of no rhyme or reason to it.
So for him, the first thing that I would start doing, let's go this way. So for him, because it's kind of like there's no rhyme or reason, what I would do is probably start tracking what he's more or less consuming that day, and specifically looking at like maybe closer to bedtime what he's doing. So fluid intake, how often is he going to the bathroom? It's difficult because if they go to daycare, you kind of need to have your daycare on board as well to document these types of things. Making sure there's none of those bladder irritants, especially as you get closer to bed, and sort of seeing if that makes a bit more of a difference.
Okay.
Yeah. Because it's the first thing is always, my plan of action is always like, we need data to sort of see what's going on, because otherwise we kind of just we start trying everything and then we think that nothing's working. But if we start with just a bladder diary, like when is he going? What fluid is he having and how much of that? What does his diet more or less look like? Like if you can document exactly what he's having, great. And then seeing sort of like then tracking like which mornings is he having, is he peeing the bed and what time is it? Right. Because then you can kind of go like, okay, over the span of a week or two, you might have a really good data as to what tends to be most consistent as to why he's peeing at nighttime.
Okay.
Yeah.
Perfect. Thank you.
You're welcome. Okay.
Oh. Hi, Vanessa.
Hey.
So going back to my quick question for you. So my daughter is going to be 6 in the summer, and she has always worn, we call it a nighttime, like a pull-up. If we want to get rid of the night times and try the program that you offer, do you suggest, like, I think our biggest battle is we kind of give up, I think, and we go back to the night times. So is it maybe a good practice to just be done with the night times and, do the laundry, do the program, keep trying, even if there's wetting, don't go back to the night times, like just be kind of done with them and keep trying this program? Because we've just kind of flip-flop back and forth, and that could also be part of the problem, I think.
Right. So you're talking about flip-flopping back and forth between like not wearing nighttime pull-ups and then wearing nighttime pull-ups?
Yeah, like, we get, like my biggest thing and what led me here today is I'm like, okay, she's just not ready. I don't want to push you. She's just not ready. And then, it's okay, you're almost 6, like, and we can try this, and we're going to like, again, do some of those things, like limit the water before bed. We have a little bit of a mattress protector, whatever. So we don't put the pull-up on. And I think only twice she's like, she wets it every time, and she has no idea. She'll wake up like just completely soaked. So obviously for her, she's not even feeling it. There's no attempts to get up ever, like just these deep sleeps. And then we just kind of end up going back to the pull up, because we're like, okay, like you're not ready. So yeah, but if we keep doing this, like sometimes we'll put on her nighttime, maybe a little bit too early before bed, and she'll be still awake and she'll go in it. That's a little bit of a fun thing. And we're like, no, you're awake.
Don't use it now. So I would say it's partially up to you and your comfort level as what do you feel is the right way to do. Because obviously like the dry morning program has to do with like first assessing, right? So in this case, the way we describe it as like, you're just checking in on the kid. So if you're more than happy that you go to check out on her 10 o'clock and you notice the bed is wet and you have to change everything, then you can go ahead and do that. The other example is, I mean, if you do want to just stick with the pull-ups just for the week of testing her, right, of understanding like what is her pattern, it's also really easy to do, because then you don't really have to wake them up, right? Because if it's just a pull-up that's slightly wet, you don't have to change her and get her all up and wake her up. You could just know 10 o'clock, she's already wet, right? Let her sleep. Okay. And you could do that every single night for the first week.
Okay.
Yeah. And then after that, because the concept is you're waking them up before they go, then you, by all means, and maybe after the first week, you just say, done with the nighttime pull-ups because now you're no longer going to need them.
Right. And then just do laundry, try this, this program, try waking her up. And I think that's the biggest thing is this morning program sounds like something I'd like to try for sure.
Yeah, I think it is helpful to use. Give it a try. There's everyone always thinks it's like a perfect scenario, right? But there will be some things that kind of question, but by all means, give this a try and the bladder irritants, looking at her overall day, how it's going, and try your own modifications that way.
So maybe try the program. And then if that's not working, maybe try some, I was also interested in the thing that wakes them up, like the alarm.
Yeah, the alarm systems, right?
Right. But maybe try the program first before the alarm.
I would try
the alarm.
The alarm is just a bit of it's kind of annoying. It is just like usually it's like, think about like a baby monitor. It's an alarm that wakes you up and the kid up, especially like on the age of 6. They're not necessarily really good at being like, an alarm is going off, I'm going to go to the bathroom, right? It's mostly an alarm for the parent to wake them up, to have that conversation about.
Oh, I see. Okay.
Yeah. So then you go like, well, if she's not really noticing that she's even gone, perhaps the alarm system won't work so well for her right away.
So if they're not noticing that they're going and they wake up like, with obviously a lot of pee in the nighttime, then perhaps best to try tracking the pattern and then trying the program.
I would track the pattern first. I would track the pattern and try the program first. The alarm requires a lot, there's a lot more pieces to that puzzle.
Okay. Thank you.
Yeah, you're welcome. Okay. I think that's everyone's questions for now. All right.
Vanessa, I just wanted to say thank you so much. You did such a good job and it was so informative. So thank you so much for donating your time and educating all of us.
Absolutely. I'm happy to do this. I love educating people.
It was great. It was really, really great.
Thank you. Okay. Well, it was lovely having everyone on here. I'm just going to stop my share so I can see everyone. And then I will let everyone have a good night. Okay. Thanks. Bye. Yeah.